Hi, my name is Alexia Zerba, and I'm going to be talking about liver disease, coagulopathy. So, what is liver disease, coagulopathy? It involves problems with how your body makes blood clots. Generally, in the liver diseases, it's a complex state of rebalanced hemostasis. The failing liver synthesizes fewer clotting factors, but also fewer anticoagulant proteins. And this leads to patients carrying risks for both spontaneous bleeding and thrombotic events like portal vein thrombosis. The role in the coagulation cascade: the liver is responsible for producing almost all clotting factors like fibrinogen, prothrombin, factor 5, 7, 9, 10, 11, 12, and 13. It also synthesizes anticoagulant proteins like antithrombin, protein S and C. And liver disease, decreased production of these factors prolongs PT/INR and impairs clot formation. So generally you'll see low platelets, low fibrinogen, weak clot formation, portal hypertensive bleeding. For clotting, you'll see low protein C and S and antithrombin, increased factor 8 and VWF, and increased risk of portal vein thrombosis or VTE. Some populations affected: coagulation abnormalities occur in the majority of patients with advanced cirrhosis because the liver produces most coagulation factors. 58.4 million are estimated global cases of cirrhosis in 2021. Some higher risk groups involved are advanced cirrhosis or acute liver failure patients, alcohol-associated liver disease, hepatitis A, B, and C, and certain cancers. The clinical presentation of liver disease coagulopathy is typically easy bruising, often related to thrombocytopenia and platelet dysfunction, GI bleeding, mucosal bleeding, procedure site bleeding, thrombosis, splenomegaly, and jaundice. Genetic and disease associations: liver disease coagulopathy is acquired, not inherited. So main disease associations are usually cirrhosis from alcohol-associated liver disease, MASH, chronic hepatitis B or C, acute liver failure, autoimmune liver diseases, vitamin K deficiency, or malabsorption. There is no single inherited gene cause for liver disease coagulopathy. However, inherited thrombophilias can coexist and increase clot risk. Some liver diseases do have genetic causes, such as hemochromatosis or Wilson's disease. Lab evaluations and expected results. Conventional tests show abnormalities but do not fully predict bleeding risk. Some typical tests will be PT/INR, which will be prolonged and increased. APT will be normal or prolonged. Platelet count is decreased. Fibrinogen can vary, can be normal, low, or dysfunctional. Factor assays, usually multiple factors are low. And for D-dimer, it can be elevated, which reflects fibrin turnover. So treatment and management, and I apologize in advance, I am going to butcher this. Active hemorrhaging and fibrinogen. Usually want to target a fibrinogen level of 150 milligrams per deciliters by giving cryoprecipitate or fibrinogen concentrates. Fresh frozen plasma is reserved for active and severe bleeding. It is frequently avoided for routine procedures because it may not effectively correct the hemostatic balance. Platelet transfusions can be used for active bleeding when counts are lower than 50,000 per microliter. Antifibrinolytic agents for people experiencing severe rapid clot breakdown, medications like tranexamic acid or aminocapurosidic acid may be used alongside cryoprecipitate. Vitamin K is often given just to rule out concurrent vitamin K deficiency. And these are my references.